Now I invite Dr. Akshay Nair. Dr. Akshay is NRK oculoplastic surgeon, I would rather say. He did his basic medical education from Mumbai and later then did his fellowship from LV Prasad Eye Institute and his further subspecialty fellowship from New York. Now currently he is practicing in Mumbai and he is very famous over here. Once in a while he visits his hometown, no?
Supposed to be.
Yeah, okay. Thank you. Over to Akshay.
Thank you so much, Marian. So I'm going to talk about, when she gave me the topic of what is new in ptosis, there's actually nothing new in ptosis, but still there are, ptosis is a condition and a surgery that's constantly evolving. So I thought I'll present a little bit about what is old in ptosis, which we should not forget, as well as a little bit of what is new in ptosis. So this is an interesting thing that I keep finding that pops up on my YouTube feed about what is new in ptosis. And they talk about face yoga and exercises to correct ptosis and droopy eyes. And if you once in a while are feeling low and need a good laugh, I recommend that you watch these videos. They are hilarious. And for the record, face yoga doesn't help in improving ptosis. So when I'm talking about what is old in ptosis, I'm going to go past some important things that as oculoplastic surgeons and as ptosis surgeons, we shouldn't forget. So these are like 10 commandments which I have created with, these are my mistakes. These are things that I've learned from others' mistakes, trying new things, because at the end of the day, we have to keep evolving and learning and not take ourselves too seriously, because there are times where we will also make mistakes. Because ptosis is as much as an art, ptosis correction, as it is a science. So this is what's old in ptosis, but unfortunately things that we cannot afford to forget. So my rule number 1 is documentation. Every visit of any patient, not just ptosis, I always take photographs. The entire preoperative session includes pre-op photos, counseling, when I discuss surgical options, and again photographs on the day of the surgery as well. And I always recheck measurements. This also helps you to streamline your plan, confirm your plan on the day of the surgery. Because patients will sometimes come and tell you after ptosis surgery there is absolutely no difference before and after. And patients may not appreciate or understand the difference. Patients may lie, but photographs don't. So always document. So this is a patient who came, now this is coming to my second rule. Now this is a patient who's come, 22-year-old patient, male, congenital ptosis. You can see the levator function is very, very minimal. And he's got a slight Marcus gun also. 618 right eye, 66 left eye. What surgery would you prefer? Any options that you offer this patient for a surgery? A levator resection or a sling? Sling. So I always look at the patient, and if you see the brow position, the patient is actually having no incentive to lift the brow. He's amblyopic in that eye. So unless you have a sling which statically lifts the eyelid, he's actually not going to use his eyebrow to lift the lid at all. So there is no frontalis action, and at the end of the day, tarsofrontalis sling is a surgery where we harness the power of the frontalis to lift the tarsus. So if there is no frontalis action, he's not going to lift his eyebrow. So this was a patient in whom I ended up doing a supramax levator resection, because we traditionally are taught to decide surgery on the basis of levator function and not actually the patient's physiology. So sometimes they really don't use their frontalis, and in those patients a sling may not really help. So be flexible and improvise, do what is needed and not what the book tells you to do. Now look at this patient here on this. You can see the frontalis overaction. You know he's trying to lift the eyebrow with his eyelid with his eyebrow. He's going to be a good candidate for a tarsofrontalis sling. Similarly, this is a candidate whose eyebrows in normal position when trying to open his eyes are not arching. The frontalis is not working. So in this patient, I would do a supramax levator resection, and that's exactly what we did, and we are able to get a good outcome. So rule number 2 is be flexible. Moving on, this is a patient, minimal Marcus gun, as you can see, and this is a child who's got again mild ptosis but huge Marcus gun. So I always ask the patient, what is it that they want to be treated? Because each case of Marcus gun is different. listen to the patient concern. Oftentimes, I always ask patients with Marcus gun, what is it that bothers you? Is it the drooping or the ptosis that bothers you, or is it the Marcus gun that bothers you? Because if you have a fixed plan in your head without listening to the patient, with a hammer in your hand, everything that you see is a nail, and you're going to be hitting it. So you have to come up with, address the patient's concerns individually. If it's only ptosis that bothers them, ignore the Marcus gun, just correct the ptosis. If it's the Marcus gun that bothers them, customize your surgery so that the Marcus gun is abolished, which means a levator excision and a sling. So answer their questions carefully and don't lecture them on ptosis surgery. They're not a fellow. And these are things that I've learned on my own. Patients don't want to know the technical details. They need to know what helps them. All right, so this is case number 4. A 2-year-old girl came accompanied by the father. Father said left eye droopy since birth. Investigations were done. We are planning left eye resection. On the day of the surgery, mother comes and tells father doesn't know anything. Both eyes are droopy. Then you don't operate only one eye. And imagine my fright when the patient came like this on the day of the surgery. So this is a case of myasthenia. Myasthenia does not have any restriction on age of presentation, eyelid of presentation, motility, ptosis. So going back to rule number 1, document. If I had not taken photographs, nobody would have believed. That child had a thymoma, which is why 10% of all myasthenics under the age of 40% have thymoma. So if you have a child or an adolescent who's suspected of myasthenia, always get a CT chest. The 73-year-old male had a recent history of head trauma and diplopia. 2030 was the vision, and this is his motility. It doesn't fit into any particular nerve palsy. So a neuro-ophthalmic colleague of mine did an MRI. MRI was normal and said he's had a trauma. This is partial traumatic third nerve palsy. That's like a new recipe of a dish he's made, because there's nothing like a partial traumatic third nerve palsy. All the patient needed was an eyes test, and the patient motility and ptosis had completely resolved. So as you can see, diplopia also went away. The history of trauma was just superfluous. So at the end of the day, rule number 4, eyes is nice. Every patient of ptosis who gives us even the slightest diurnal history variation, a diurnal variation history, get an eyes test done. Eyes test is where you keep the ice packs on both eyes for 2 minutes, and at the end of 2 minutes, a 2 millimeter difference in the height or improvement of ptosis is a positive eyes test. This is case number 6. So the 43-year-old female, history of domestic abuse. She received a slap by her partner. Their blurred vision and ptosis. MRI was done. It was called again third nerve palsy causing ptosis. Motility was fine, given oral steroids, and after a month was sent to me for ptosis surgery correction. This is Feb 2021. I did nothing, called her back in 3 months. April 2021, did nothing, called her back in 3 months. June 2021, she is nearly normal. So I think we also need to know, apart from which cases to operate, which cases absolutely not to operate. History of trauma, for 6 to 9 months, I would absolutely not even think of doing anything, especially if the patient has had a post-surgical, like a RD surgery or a cataract surgery or a posterior subtenons injection, which can cause some ptosis. Wait for 6 months. Don't revise, just reassure them. They'll come back to you and they'll be very happy. As oculoplastic surgeons, we should also, again, be flexible in our technique. Careful case selection of those patients with mild ptosis with a positive phenylephrine test. A posterior approach, conjunctiva Mueller's resection, is a very good option. So don't risk, especially for mild 1 to 2 millimeters ptosis, I prefer to go to the posterior approach. So always add that skill into your armamentarium. I know Dr. Unavar is here, and he's a fantastic proponent of Fasanella servat, but I'm not a big fan of it. I don't think sacrificing the tarsus for a fault of the levator is something that works well in my hand. So I prefer a conjunctiva Mueller's resection for these patients. So don't be afraid of the posterior approach, and do learn it. It's a very simple surgery. I won't go through the surgical steps for sake of time. But at the same time, master your anterior approach, because at the end of the day, if a posterior approach surgery doesn't work, your anterior approach surgery is going to be the route to revise it. It is a familiar route for all of us, as Dr. Anis showed in those wonderful videos where you can go through the lid crease even for an orbitotomy. How do you do that? I think we all need to, at any stage in a career, understand our algorithm. Just like cataract surgeons have surgical induced astigmatism, not everyone's levator resection surgery is identical. We need to know how much of resection creates how much of lift in what, severe, mild, moderate ptosis. So we know exactly what is our surgical correction in our hands and approximately come to with our own algorithm. So we can revise, and if in this case we are able to predict our outcomes, even revise them in 1 week under topical anesthesia or even local anesthesia. The next thing, rule number 8, is pay attention to contour. Contour is extremely important because no two patients have the same contour of the eyelid. Now look at this patient, it arches flatly and then goes down medially, whereas the patient below has a nice curvilinear contour. So contour is key. Mark the lid crease, which is the highest point, and then mark the contour, because contour will guide the suture placement in ptosis surgery. And even now, doesn't matter how much experience you have, it's always good to mark the lid crease with a caliper for every case. I was visiting Dr. Bob Goldberg, who even now for every ptosis surgery marks the lid crease himself with a caliper. So I think if he does that at his level, all of us should do that, because it adds a little bit of more precision to our surgeries. And case number 10, can I have 1 minute? Okay. This is a case of a 44-year-old diabetic, ptosis in right eye for 4 years, went ahead, did ptosis surgery, and she comes back and tells me, you've made my right eye look good, but my left eye looks small. And of course, I looked silly because I did not pick up the Herring's phenomenon. She had to then undergo surgery in the other eye. And how do we know that she had ptosis, which I didn't check? Look at the eyebrow position. Her left eyebrow is elevated, which is masking the left eye ptosis. So there is brow elevation lifting both eyelids, but the ptosis is more severe in the right eye, so the right eye is unmasked. Now when the right eye operated goes up, the lid just drops because the lift innervation drive is no longer there. Herring's is a very, very real and very commonly seen phenomenon. We need to be a little more careful about it. Gentle negation of the frontalis is the way to assess Herring's while we do that. And again, remember rule number 1, without documentation, we would not be able to get the idea. Again, this is a photograph of a patient with ptosis in one eye. And now look what happens when she looks down. When she looks down, the ptotic eyelid goes up. So this is a case of an aberrant reinnervation following a third nerve palsy. And these are cases. Now imagine if we operate to lift that ptotic eyelid, she will have complete lag of thalamus with corneal exposure on blinking, because when she looks down, the lid retracts. So not all cases of ptosis must be operated. I'd happily refer him to my competitor, oculoplastic surgeon in Bombay, that this is not a thing that I want to take up. Whether it's poor ocular motility because of CPO, where you want to plan an undercorrection, or aberrant reinnervation, regeneration, poor bells, these are cases you don't want to touch. And finally, red flag patients whose prior complaints is not ptosis, but previous visited surgeons who said that she did this, he did that. Patients who had multiple procedures are unsatisfied. They have an obsessive approach, will ask for a mirror and keep demonstrating things which even as an oculoplastic surgeon we can't find on their face. Unrealistic expectations, excessive negotiation about the cost of surgery, repeated cancellation, rescheduling the surgical date, wanting eyelids like Deepika Padukone or Katrina Kaif for XYZ. These are all red flag patients who are best left alone and do not get operated by you, because they are not going to get satisfied by whatever procedure you do. So a quick recap on our pearls, which is documentation, be flexible, listen to the complaints patients before surgery, because otherwise you will definitely have to listen to them after surgery. Use the ICE test, be aware of which cases not to operate, pay attention to the eyelid contour, and Herring's phenomenon is something that. So is there anything new at all? Well, actually there is. We talk about frontalis flap as the latest thing in oculoplastic surgery. Well, in fact, it's not the latest thing. It's been there for almost 30 years. So frontalis flap is where we use the frontalis muscle to create a flap and lift the eyelid instead of the levator. My only piece of caution of advice for frontalis flap is that lag of thalamus post frontalis flap is lesser than that of sling, but it takes up to 4 to 5 weeks for the lag of thalamus to resolve. This is a patient at 1 month post-op, and you can see that the lag of thalamus is still there. In about 25 patients of frontalis flap I have done, 2 have developed exposure keratopathy and ulcers. So now I actually leave behind the frost sutures for at least 3 weeks after frontalis flap. But eventually they do very well. This is a patient with a frontalis flap. Amazing contour and amazing lid crease is seen, and patients are very happy. It appears more physiological. And finally, Upneek with his topical oxymetazoline eye drops, which are used, not available in India. A word of caution, I know it's the same as our nasal decongestant, but please don't put the nasal decongestant in the eye. It does not work that way. Thank you for your time, and thank you for the invitation, Dr. Marian.
Thank you so much, Dr. Akshay, for that eye-opening presentation on ptosis.